So I'll stop speaking and we'll listen to Farah first, Professor Farah Magrabi, who needs no introduction, and she's the first speaker. Thanks, Farah.
So thank you, Professor Patrick McNeil. So in my talk, what I'm going to try and do is essentially summarize some of the research highlights from the last 10 years, and then really it's mostly forward-looking into the world of AI, where we are starting to research its clinical safety as well as effectiveness. So fundamental to our work, a really fundamental idea is that errors in clinical information harm patients. If you think of a simple prescribing system, when a clinician orders a medication and data can go missing. So basically data can be wrong. Sorry, let me start with data going wrong. A clinician orders an antibiotic, but a completely different medicine appears in the pharmacy system. That increases the risk that the patient might receive the wrong medication. Data can go missing. So a penicillin allergy that has been documented, if that fails to appear in the patient's medication record, again, that can pose a risk. Data can be partial. So think of a discharge medication list, which includes the names of the medications, but not their dose. A primary care physician may order the medication correctly, but at the wrong dose. Data can be delayed. Think of a hospital system. A patient needs to receive the medication urgently. The doctor orders the medication, but it's not received or doesn't appear in the patient's medication list in a timely fashion. And so that medication is delayed in terms of being given to the patient. So these are just some fundamental ideas. I mean, we've talked about all of the benefits of digital health systems, but they're like any other technology. They can fail, and the failures can also occur when they're interacting with humans as well. And these are sort of fundamental ideas that have guided our research. So the patient safety informatics stream at the center is structured into three main areas of work. Fundamentally, we are monitoring the safety of digital health, digital technology, and AI. So this is essentially about collating data to identify risks, both using manual as well as automated methods. The second stream is the human-AI interface, which has already been mentioned. This is about studying the effects of these digital systems on human performance and then working out how to use them safely. The third stream of work is very much focused on looking at how to safely implement as well as operate new AI systems. Basically, how do we integrate them into the existing clinical workflows as well as the IT infrastructure? And of course, I have an amazing team of computer scientists, psychologists, clinicians, and biomedical engineers who makes it all happen. Most of them are here today or attending online. So we've had a pretty good run over the last 10 years. Here are some of the research highlights. We started back in 2010 working with Professor Bill Runciman. We collated Australian incident reports to show that problems with IT systems can pose safety risks. We developed a classification of the types of human as well as machine problems to describe these risks. That classification was fairly quickly picked up by health systems in the USA, UK, Canada, as well as in Australia. In 2018, it came to be adopted by ISO, the International Organization for Standardization, and in 2020, it was adopted by the Commission for Safety and Quality in Australia. We then moved on to data in the US. So the Food and Drug Administration, which regulates medical devices in the US, we were able to analyze their data and basically identify that problems with IT systems and really link them to patient harm as well as death. So with the Australian incidents, we showed that IT problems disrupted care delivery, but with the US data, it was the first time that we were able to link it with patient harm and death. We also designed methods for the surveillance of hospital processes. Essentially, what we were doing when we were trawling through these incident reporting databases was that we were searching for IT incidents by hand, and this was a highly resource-intensive task. So to then address this issue, we turned to statistical text classification and showed that these methods could be used to detect IT safety events. We then looked at safety events across the English Nhs. So at the time, the English Nhs had implemented a whole lot of systems across a large geographic area. We were able to analyze 6 years' worth of that data and for the first time show that IT problems can harm patients on a large scale. So many thousands of patients being affected by a single incident. And of course, now it's pretty obvious. We see routinely large-scale events, a single server or a single system coming down, affecting many thousands of patients. But this was the first time we were able to collate that data to show that it was real. We also found in this data set that human factors issues were proportionally higher in the events involving patient harm. So basically, when technical problems occurred, they disrupted care delivery. The risks to patients, we couldn't really identify them. But when the human and machine interface breaks down, we could see that patients were directly harmed from these incidents. We then looked at IT safety events in general practice. So this was work with Michael Kidd and Teng Liao. We set up our own incident monitoring system called TechWatch and showed that safety risks were quite real in general practice as well, which was highly computerized, including the hybrid records, which pose risks as well. So when the transition from paper to electronic is not complete, you have a parallel paper record system. And that contributed risks to patient safety as well. System transitions were also a risky thing because GPs were routinely updating their software on a monthly basis, and every time there was an update, something would go wrong. And I'm sure GPs in the room would relate to that in terms of disrupting care and affecting patients as well. The other one was moving from one record system to another. I mean, we routinely do that now, but these are all times of high risk, and we had data to show that this was real. We then, my pointer is not working. Hang on. Guys, my pointer is not working. Simon? Move out of it. It's just stopped. Cool. We then moved on to looking at consumer health apps, which have already been mentioned. And so we found a whole lot of risks with consumer health apps, and we're able to publish that work as well. And more recently, we've gone back to looking at the US FDA data, this time for looking at the risks of machine learning systems in clinical settings. Cool, it's working again. Alrighty. So essentially, that was kind of all of the stuff we've done for the last 10 years. Now we've kind of moved on to looking at AI systems in clinical settings. And a fundamental idea or foundational to our current work is an understanding of how we are starting to embed machine learning in clinical systems. This was a study that we published last year. So essentially what we did here was that we went back to the US FDA data. We looked at all of the medical devices that had been approved by the FDA. The goal in this study was to really look at AI in context of the clinical task, and we also looked at the level of autonomy. So each AI system was, each device had some kind of machine learning algorithm or method embedded in it. It was being used for a certain clinical task. The device was receiving input and then providing a certain output for the clinician to use in that clinical task. What we found was that most current devices are supporting diagnostic and triage tasks. They're providing clinicians with information to support decision-making. They're also providing decisions in a small number of cases. But overall, there is limited autonomy. Present-day AI systems, they basically require clinicians to confirm information and to be responsible for the decisions. We found 3 levels of autonomy in current devices. The first was where devices are providing information for humans to use in their decisions. The example I have here is a device that is analyzing CTs of the lung and is providing information or quantification about the lung volume, lesions, as well as lung lobes. We call this autonomous information. It's characterized by a clear separation between what the device is doing and what the human is doing. The device is basically providing information for the clinician to use in their task. It can basically be thought of as a calculator. So clinician is accepting that information and then applying it for the clinical decision. The second group of devices we found were where devices are assisting humans to undertake clinical tasks. The example I have here is an AI that is analyzing ECG signals and identifying abnormal cardiac rhythms. We call these assistive devices. They are characterized by an overlap between what the clinician and the device is doing, because both are meant to be identifying these abnormal cardiac rhythms. So essentially, the AI is behaving as a second pair of eyes, and the manufacturer's information clearly states that clinicians mustn't use the AI as the AI-generated output as the primary interpretation. They actually responsible, and the responsibility for the final decision basically rests with the clinician. And what's interesting to note is that the majority of current devices fall in this category. So almost half of the devices we looked at fall in this category, where both the AI and the clinician are meant to be kind of operating side by side. And we think that this is one of the important areas where, things are likely to get interesting in terms of risks. The third and final group is where AI decides in place of a human expert. The example I have here is a screening system. I'm sure you've come across this if you are interested in AI in healthcare. So basically, this is a system that detects diabetic retinopathy. A GP can basically act on positive findings and refer on those patients onto a specialist for diagnosis and treatment. And the advantage here is that they don't need to interpret those retina photographs themselves. This is autonomous decision. Basically, the AI is providing a decision for the clinical task and can be enacted on. The FDA, so essentially, the AI is providing the decision that the clinician can act on. The FDA actually issued a warning about some of these systems just recently. Essentially, this was an open letter to clinicians highlighting the limitations of these systems. The particular device they highlighted in that open letter were AI that were basically being used to speed the prioritization of potential stroke cases. So looking for obstructions in one of the large arteries in the brain and then flagging stroke patients to be triaged more quickly. And what the FDA was warning clinicians was that these devices are not a replacement for radiologist interpretation. They can't be used to rule out the presence of certain findings. So essentially, clinicians need to still look and interpret these images themselves. They also need to look at all of the images that are not flagged by the system. And one of the most important things is that they're only for a specific artery, they're not for all arteries. So again, clinicians need to look broadly at everything else that the system is not flagging. So we see that it all is going to come down to how these systems are implemented and used in clinical settings. You can have a well-performing system, but it may not work as well once we're integrating it into clinical workflows. So we talk about this journey of an AI system, essentially from a bright idea to a real-world implementation in terms of the last mile, because the journey can be broken down into 3 parts. The first part is data curation to build the model. The second part is where you're building and testing a model. And then the third part is where it starts to get really interesting, how you about implementing it and using it in a routine setting. And so most of our current work is focused on this area, where we're working with health services as well as companies to help them implement and evaluate their systems in complex clinical settings. And there's sort of many questions and challenges at this interface, the first of which is generalization. So an AI that is trained on a certain population it might need to be tuned before it is deployed. So we all know that AI systems get developed where data is available. But again, that population might not match the population of where the system is deployed. So the example I have up here is a fictitious one. So if you have an AI system for diagnosing skin cancer and it's trained on data from a Caucasian population, but you're deploying it in a population that is quite mixed, it needs to be tuned before it can be deployed in that setting. And then we've already talked about integrating these systems into clinical workflow. So essentially thinking about the people, process, and technology. So who's going to use it? What's the broader clinical process? What are the other IT infrastructure and tools in that environment? Take, for example, an AI system that is designed to assist clinicians with chest X-ray interpretation. So here's one that has been approved for use in Australia. It basically detects 124 radiological findings. The image on the left is the original chest X-ray image. The image on the right is the one that the AI has interpreted. And this AI system is quite neat in the way that it's designed. It provides the findings, but it also provides the degree of confidence, which is that bar shown at the bottom. And so one setting where a system like this might be particularly useful is the emergency department, where chest X-rays are taken for about 50% of patients. And often clinicians need to make decisions in advance of the radiologist's report. But when it comes to implementing the system, we really need to think about how chest X-rays are taken in the ED. So some are taken on portable X-ray machines, some are taken on fixed machines. At the portable X-ray machine, the clinician might interpret it quickly as it's taken, and then another group of images might be kind of transmitted to a workstation for interpretation. So we really think about what's the clinical process and how do we integrate the system in the best possible way to ensure that it improves diagnosis, management, and then ultimately the disposition of the patient. And once we kind of deploy a system, it kind of doesn't end there, because the performance of the system needs to be monitored, because the population might change over time. Like say in 2022, we tuned the system, we deployed for that population, which is highlighted there, so mostly young people under the age of 59. And then in 2 years' time, the population that we're seeing kind of changes in the healthcare setting. So again, we need to be monitoring to see how well the AI system works as the population changes over time. And so that's the issue of calibration. One example where this has played out recently is in AI for identifying possible sepsis cases. So essentially, the old rule-based systems don't work that well, and AI systems are starting to replace them. So the graph here shows the alerting rate from one such sepsis system that was deployed at 24 hospitals across the US. Each line on that graph depicts a hospital. And the darker lines are bigger hospitals. The x-axis is basically the days from COVID. So at the 0 mark is when COVID hits, and then we're seeing the graph of the percentage of patients where an alert is generated. Let's just leave the background highlighting for a moment. And so what we see here is that the alerting rate in the days before and after the first COVID case hits. And so what we see is that even though the hospital census is declining, so as soon as COVID hits, hospitals cancel their elective surgeries, they're seeing fewer patients, but the alerting rate is going much, much higher. And so what we see happening here is that the rates of sepsis go up during COVID, and the system starts to generate a lot more alerts, many more than the nurses kind of keep up with. So what ultimately happens at one hospital at least was that over a third of patients were generating sepsis alerts. And so nurses became desensitized to those alerts because they were already monitoring those patients really closely, being COVID patients. And so they actually had to turn off the alerts on day 21. So not only, we need to really think about how the systems are going to work with humans, but then the use of the systems ultimately affects human performance as well. And we all experience this on a daily basis. the first of which is automation bias. So the use of these automated systems makes us complacent. Even with simple systems like a GPS, where we can easily verify where it's taking us, we tend not to do so. There might be lots of reasons for this, and good reasons. We might be rushed, distracted, or focusing on something else, like an amazing conversation. But this tendency to use automated cues as a heuristic replacement for vigilant information seeking and processing is called automation bias. So basically, we're following the machine, even though it may take us the wrong way. And this happens when automation works well, but not perfectly. So this is work done by David Lyle, who demonstrating these effects. So basically, this is automation bias with a simple rule-based system. This was a controlled experiment where the quality of prescribing alerts was varied, and the participants could easily verify these alerts. The graph on the left here shows errors of omission, which is essentially a failure to detect prescribing errors. And so what we see there is that with the decision support, there was a 41% decrease in prescribing errors, showing the effectiveness of having decision support. But when the decision support was incorrect, we saw an increase in errors. Similarly, for commission errors, so these are the acceptance of false positive alerts, we saw that there was a 57% increase when the CDS was incorrect. Okay, so there are a whole bunch of other effects of automation bias as well that we're interested in studying. Automated systems affect mental workload, and again, we experience this on a daily basis. When systems are well designed, they can organize information and help us manage our workload. But workload is increased when systems are hard to initiate and engage, and again, when they require extensive amounts of data entry. The second is that because when we're using automated systems, we don't really monitor the environment so actively, we tend to lose awareness of the broader sort of situation. So we lose situational awareness, basically from not having to monitor sources in the environment. And of course, our skills degrade as well. So there's a whole generation out there who can't drive without a GPS. And so we're less skilled at reading a map and navigating by landmarks. And so we really need to think about which are the skills we want to preserve and which are the skills we're kind of willing to trade off for using some of these automated systems. So to summarize, we know that our efforts to ensure the safety of AI in healthcare, they needed to be guided by the level of autonomy in these systems. We know that AI systems in decision support, they provide information, they assist humans to make decisions, and they provide decisions as well. We need to think about the last mile of implementation and use, thinking about issues of generalization, integrating with workflow, as well as calibration. And last but not least, the use of AI affects human performance. We need to think of automation bias, as well as workload, situational awareness, and what's going to happen to our skills. So in closing, I just want to acknowledge some of the important people who've been part of this journey. We're very grateful for the support that we receive at Macquarie University for our research, and of course our partners, who, without whom this work wouldn't happen at all. So thank you very much.